My name is Oliver Ganzler. I'm Vice Chairman of the Department of Neurosurgery in Erlangen. If you don't know, Erlangen is a small university which is about 180 kilometers north of Munich. And we have a big surrounding, certainly about 2.5 million patients in our district. And I want to talk to you about the interaction between radiosurgery, stereotactic radiotherapy, and neurosurgery, which is a big field, a big emerging field, and is becoming more and more interesting for us neurosurgeons. As you know, radiosurgery was conceived many, many years ago by Lars Wexner, who actually tried to destroy a target with radiation, ionizing radiation. And that was the concept many years ago, to destroy a target with stereotactic means. The old thinking of neurosurgery was, until some years ago, that we should at all costs try to resect a tumor, any kind of tumor, skull-based tumor, myeloma or whatever, as aggressively as possible without costs, because this would be a cure for the patient. Now we think that the tumor removal at all costs is not longer what we should do, but we should look at the preservation of the patient's function. And in this context, radiosurgery and surgery grow together. So tumor removal at the cost of function loss is no longer acceptable. The goal is not total tumor removal. Our goal should be tumor control. And with the help of modern concepts of surgical navigation and radiotherapy, we can conceive this goal. So in Erlangen, a couple of years ago, we thought about buying a gamma knife, or should we buy a gamma knife or not, and then we decided to achieve a Novalis system, because this Novalis system gives us the possibility to use interactive bridge-guided surgery and radiotherapy together, and we work together with our colleagues from radiation oncology as a team, neurosurgeons and radiation oncologists. And these are the patients we treat. As you can see, we treat a lot of metastases here, but also almost half of our patients are benign tumors. I hope you can hear me. The half of our indications are benign tumors. And I want to show you a couple of things we do in Erlangen, and then later switch on to our image-guided surgery concept. So let's start with metastasis. You know, it's the most common intracranial neoplasm in adults. It's very difficult. The prognosis of these patients is very dim. And if we cannot resect them, or if the patient has multiple metastases, we switch to radiosurgery or to hyperfractionated stereotactic radiotherapy, which is a good concept for these patients. In Erlangen, if the tumor volume exceeds 3 cc, we do fractionated radiotherapy. If it's below 3 cc, we do radiosurgery with constraints to the brainstem, of course, and so on. And we, whenever possible, we try to give 20 greater than 90% isotopes. And here are some examples that you already probably know from your own experience. If you have radiosurgery, for instance, this is a lung cancer metastasis that we treated, and 3 months later the metastasis has gone, and this is a very good treatment for this patient. Again, metastasis of a malignant melanoma in the right, in the insular region, and after surgery, after radiosurgery rather, the metastasis has gone. So what can we do if the metastasis is very large, or if the patient has several metastases, and we can switch on to hyperfractionation protocols like this one. And this is patient, this is a protocol we use in Erlangen, 5 times 7 gray or 5 times 6 gray to the 90% isodose. And this, for instance, is a patient with a large 2 metastases of a breast carcinoma. And this is after treatment with hyperfractionation. As you can see, this is a very good result, almost as good as surgery. Okay, I'll switch on to another topic because we are lack of time. Pituitary adenomas is a large topic in Erlangen because we are one center for endocrinological surgery in Germany. And here again, you know there are inactive adenomas and active adenomas, and if you want to treat these adenomas with radiation, you have to know that these need and require different radiation protocols. Of course, you can treat some with medication, but most of the tumors are not amenable to medication, and you have to treat them by surgery or radiation surgery. And another problem is that pituitary adenomas tend to recur up to 40% in 10 years if you wait long enough. And if you have invasive pituitary adenomas, invasive to the coronary sinus, they tend to recur again. So, what can we do, or what adenomas should we treat with radiation? Adenomas that have an incomplete resection, adenomas that show regrowth, recurrence, and in some cases the patient is very ill, or if there are other reasons, we can choose a primary treatment. And our goal for inactive adenomas is of course tumor control. So, just to show you how is the tumor control in radiotherapy of adenomas and radiosurgery. It's excellent, about 95 to 100% in different studies. So radiosurgery is a very, very good means of treating adenomas which we cannot resect. Of course, you have to take care of the optic nerve, and our policy in Erlangen is if the tumor has a distance of less than 4 to 5 millimeters, we don't do radiosurgery. Then we do fractionation protocols. And the chiasm should not get more than 8 gray, otherwise you have severe neurotoxicity after several years. In functioning adenomas, let's say in acromegaly or Cushing's disease or so on, you need a higher dose, which is 18 gray in Erlangen, 18 gray to the 90% isodose, whereas in inactive adenomas you can choose 12 gray. And these are some examples. This is a Nelson tumor, a recurrence of Cushing's disease after bilateral atherectomy. And you can see here the invasive tumor, which was irradiated with the Novalis system. And the patient had a very good tumor control afterwards. Another case here, acromegaly. This is the GTE, 0.5 cc, very small. And you can see here the distance to the optic nerve is quite good. This is an ideal case for radiosurgery. And these are larger tumors that compress the optic chiasm, which you cannot treat with radiosurgery, otherwise the patient would get blind after months or years. And these are very good to treat with fractionation protocols. There are some instances, if you have the possibility of image-guided surgery, I will show you later. We have an intraoperative BrainSuite, and this is a patient we treated within the BrainSuite. This is the tumor before surgery. We already knew that we cannot resect this tumor completely because it was invasive to the carotid artery and the coronary sinus. But our goal was to remove it partially as much as possible. And this is actually an intraoperative imaging of the tumor. The patient is still anesthetized. And we saw this is what we could do. More would be very dangerous. So we stopped operation here and then sent our images to the Novalis system. Then took the patient and made a radiation plan, 12 gray to the 90% isodose, now distance to optic chiasm, and the patient was treated in 1 day, totally, which is a very interesting concept, I think. Another good indication for radiosurgery is vestibular schwannomas, acoustic neuromas, and of course, there can be many treatments. We have many treatment options. You can do resection, which is, as neurosurgeons, our first goal, of course, and we do it whenever possible. And there are different approaches. As you may know, ENT approaches or neurosurgical approaches. I like to do the suboccipital rectal subvital approach. Of course, if the tumors are very small, you can observe the patients, wait and scan, and you can do radiosurgery. So these treatment options you have to have in mind if you talk to the patient, and you have to decide what's best for the patient. For instance, this patient had a very small acoustic neuroma in intracanalicular, and he was advised to have operation, not in our department, outside. But we saw the patient after operation with this image. So what happened here, the patient had a brain contusion, probably from sputter or venous infarction. Anyway, this was not a good advice for operation. And in these cases, you have to consider if you offer the patient the option of radiosurgery. However, the tumor has to be very small, because if the patient still has sufficient hearing, you want to preserve his hearing. And this is important if you make a treatment plan, that the dose of the cochlea should not be too high. That's a predictor of hearing preservation, the dose that the cochlea gets. And with the Novalis system, you can easily change your treatment plans so you have an optimal dose distribution. This is the first plan we did. This is the second plan, which was much more adapted to the cochlea. So in vestibular schwannomas, we use 13 Gray to 90% isodose, and this is a typical example of the tumor. Pre-treatment and post-treatment, what you can see, the tumor did not shrink actually, it seems to swell, it seems to be enlarged, and many radiologists tell you then the tumor is growing despite radiosurgery, but actually it's just a swelling that you see. And typical finding, this is the pre-treatment MRI, this is the post-treatment, 6 months post-treatment. The tumor swells, but the contrast enhancement in the middle is less. This is necrosis, and then after you wait long enough, the tumor begins to shrink. And again, tumor control in vestibular schwannomas for radiosurgery is about 90 to 95%, which is a very good result you can get. This is a larger adenoma that we treated with radiosurgery, and this is the outcome. Very nice shrinkage of the tumor. Another case, large tumor with contact to the brainstem here, and this is after radiosurgery, facial nerve intact, hearing preservation until then also intact. Okay, let's go on. These are large tumors. This is a tumor I resected 1 year ago, and you can see this also tumor I decided to resect because it had contact with the brainstem, was very large, and you can see, of course, with surgery, you can achieve also very good results. And it is a matter of debating with the patient what are the expectations, what's the medical status of the patient, which is the best concept for him. And if you're lucky, you can offer the patient both treatment options, surgery or radiosurgery. Of course, this is not a good candidate for radiosurgery. This tumor is much too big, it compresses the brainstem. This is a good candidate for surgery. These are our results of hearing preservation after radiosurgery of adenomas, both fractionated radiotherapy and radiosurgery. And you can see here the Kaplan-Meier curves of radiosurgery and radiotherapy. Tumor control excellent, like in the literature. These are the post-operative quality of life of the patient. So you have very little complications with radiosurgery or fractionated radiotherapy. The next topic I want to talk to you is AVMs. Again, very difficult to treat. And again, you have in some cases the possibility to do beside surgery, which is of course, whenever possible, the best solution, do radiosurgery or fractionated radiotherapy, which is also what we do in Erlangen. If we can treat the patient, if we cannot operate on the patient, we treat him with 18 Gray or 20 Gray whenever possible, to 90% isodose in small volumes. These are typical cases. This is the PDV of a very deep-seated AVM which we treated, and this is, as you can see, the result later on. Very good result for this patient. If the AVMs are larger, we also like to do hypofractionation with this fractionation protocol. Again, you can see here a large deep-seated AVM within the basal ganglia, And this is again the radiation plan with the Novalis system, and the outcome quite good. There's much literature, I don't want to go into detail of this, but the obliteration rates in fractionation and hyperfractionation is actually quite good in a number of applications. This is an old case of a very large AVM with 8 times unsuccessful embolization, and then the patient came to us and we treated him with fractionation, and this is the post-operative image. As you can see, the AVM has shrunk to a considerable size now. Next good indication for radiosurgery is meningiomas. Again, the first option is of course surgery, but many skull-based meningioma cannot be operated on or cannot be operated completely, and then the combination of surgery and radiotherapy or radiosurgery is a very clever and intelligent concept, and Alexander Valisevich will later tell you how this concept is now realized with sophisticated software. Of course, it depends on how aggressive you resect the patient, the resected tumor. You know the Simpson grades, and if you resect the tumor incompletely, or if you have grade 2 tumor, you just wait until the tumor comes back. And these are again good candidates for radiosurgery or radiotherapy, or even hyperfractionated radiotherapy. Again, the volumes should be small in radiotherapy, radiosurgery. We give normally 12 grays, 20 to 90% isodose, like in this tumor that has grown into the surgical sinus. This is the treatment plan, and you can see how nicely the tumor shrinks after 2 years. These are big skull-based tumors that you can resect. These patients didn't wish a resection, so we tried to, and anyway, we couldn't have resected this tumor completely. So we decided for as a primary therapy, do a fractionated radiotherapy with the Novalis system. This is the plan, and we did an IMRT plan, a very sophisticated treatment plan that spared the brainstem and the cranial nerves, and this is the result 2 years after radiation. Patient died later because of another malignant tumor, but not of this meningioma. Okay, I will skip this. Sometimes it's very difficult, especially in recurrence, to really know what is tumor recurrence, what is thrombosis, what are artifacts, what are remnants of the first operation. Then you can do gadolinium total PET to really see and delineate your primary target planning volume, like in this case. So we knew that this was not a target for us, but only these are tumors. I told you that we also have a BrainSuite in Erlangen, so we have used this connectivity between these two machines, which one basically had used the same software for navigation and radiation planning. This you have seen in the talk before, how the BrainSuite works. This is the first prototype of the BrainSuite. We started in 2003 with this system. So it's a normal 1.5 Tesla MRI scanner with a rotating table and integrated navigation technology. And this is an example of how we operate. This is a pituitary case with navigation microscope. When we finished, we can rotate the patient into the scanner. I will show you this later in this video. Please look at the time scale. It's very fast. After stopping operation, and you want to acquire images, it takes not more than 5 to 10 minutes to have images. Now the operation is finished. Surgeon wants to know how much tumor did he resect, draping of the patient, then rotating the patient into the scanner. And then you can start imaging within a few minutes. So these are intraoperative images. Here you can see the speculum. The speculum is still inside the nose. It's an NR-compatible speculum. This is the tumor before treatment, and this is an intraoperative imaging. As you can see, the diaphragm is here. Tumor has been removed completely, and this is a very nice intraoperative imaging. Of course, it's not always that easy. This is a very large tumor that extends bilateral to the coronal sinus, and as expected, there was tubular remnants in the intraoperative imaging. Then we could go back and remove also this remnant. Then we did another intraoperative imaging and wondered about this structure, but it was blood clot, not tumor. And these are the images pre and post-operatively. As you can see here, this is the structure that we removed. I've shown you this. This has also been shown. Of course, you can have a couple of very nice features. If you have this BrainSuite package, you can do DTI and tractography, which is very useful in glioma surgery. And this is very fast. So before we start surgery, normally we do it on the day before surgery, we do this tractography of the patient, and we also do fMRI, and then fuse all these images into one image MR data set, and then start operating. And these are, it's a view through the operation microscope with the tumor you can see here, fMRI and DTI of the pyramidal tract, and with these information you can actually remove these tumors without awake craniotomy. We don't do it anymore at all in Erlangen. We only do functional imaging before surgery and use this data, and we have data that our complication rates are equal to awake craniotomy. So this is a tumor very adjacent to a language area, which you can see here, and this is the pyramidal tract. This is a resection. Actually, we decided to leave this because of the very close distance to the eloquent area. What you also can do, you can integrate MR spectroscopy data into these navigation data sets and then use these MR spectroscopy to delineate tumor. You can also use PET imaging, of course, and combine it with PET and MR spectroscopy, which gives very results very accordingly. So this is spectroscopy, delineation of the tumor. This is the amino acid fat. This is a typical image of a glioma. I want to show you this very difficult recurrent glioma in the left temporal lobe, which I was asked to operate upon. We did our functional imaging, DTI of language tracts. This is the longitudinal fasciculus inferior, which goes directly superior to the tumor. This is the pyramidal tract, which is very close to the tumor. And this is an intraoperative control. I did several intraoperative controls of this tumor, but at the end it was able to resect this tumor completely, and the patient did not have any neurological deterioration afterwards. She had a slight aphasia for about 2 weeks, which resolved completely afterwards. Okay, at this point I will stop, and if you have any questions, I'm happy to answer them.